Hi everybody, welcome to the 2013 Heath Lecture Series. This year we have two outstanding CEO Landers, CEO of the second largest healthcare group in the United States, and in CEObonds.com in October. Both of them provide us with a wonderful opportunity to learn from their leadership and expertise, which is the driver for the creation of the Heath Lecture Series. To start the ball rolling, I'd like to call Dr. Gregory Prostrakos, the Dean of the House School. Gregory, would you like to say a few words?
Well, thank you for coming to the Heath Lecture. We have a great speaker today, and Dr. Landers is going to be talking us about some very interesting developments that are going on in healthcare. I want to thank Zvi Aronson for organizing putting together this great. We have a tradition in this lecture. We invite really exceptional speakers, and Zvi was able to organize this great event. And I won't take any more time. Thank you again, and I will give the floor to the speaker, right? You want to say something, Don?
Absolutely, very quickly. Good afternoon, everybody. All right. It's my pleasure today. Thanks for coming today. What a beautiful day here at Castle Point. You know, the expression transformative leadership has been used a lot in the management argon, and it's probably right around the corner these days of being a cliche. But the gentleman who we're honored to have on this beautiful day at Castle Point is really an exemplar of that, and that's Dr. Steve Landers. Dr. Landers, in my humble estimation, being in healthcare for 31 years in this state, has been one of the best blessings that we've been able to have in our state, because his transformative leadership has really made a major difference in home care to the behest and the benefit of many New Jerseyans. Dr. Landers was educated at Indiana University. He got his master's from Johns Hopkins. He got his MD from Case Western Reserve University in his hometown of Cleveland, Ohio. And that certainly qualifies him to speak to us today here at Castle Point at Stevens Institute of Technology. But beyond that is really the style of leadership which he's exhibited in his time here. And that has been witnessed firsthand by many students, including four of the gentlemen that are sitting here with us today, who helped pitch in, and that's putting it very mildly, with the heart-to-heart drive in the wake of Hurricane Sandy. We were very appreciative for that opportunity, for the opportunity that all of our interns have gotten, for running our graduate programs with the Visiting Nursing Association Health Group down in Red Bank, and really across the state, all 14 counties. And with that, I want everybody in this room to give a very warm welcome to our featured speaker today, who's going to continue to enrich everything we're doing in Stevens Healthcare, Dr. Steve Landers.
Thank you. Thanks so much. Good afternoon, Dr. Lombardi. Thank you so much for including me and inviting me to be here, and for your leadership in supporting our mission as a visiting nurse service, really tending to people living in the shadows in many instances, the frail elders, disabled children, people that are really have the chips down, and the work that you've done in the leadership training programs and the internship programs really made an impact for our patients and workers. So I'm thankful to be here. As was mentioned, my background, I'm a family doctor and geriatrician, and I have an interest in public health and health management, and I've recently moved to New Jersey to lead VNA Health Group, which is one of the larger home care and community care organizations in the country. And so, you probably have, know a fair amount about healthcare, and about hospitals and the physician's office, and MRI machines and the EMRs and pharmaceuticals and genomics, and really what we kind of are in the shadows of the healthcare system. A lot of people, I think I went through medical school certainly without really knowing much about community health workers, about home health workers. It was sort of out of sight, out of mind. We in medicine have more and more become, specialists in one part of the body or one wing of the hospital. We have, hospitalists, intensivists, and residentialists, and so what happens outside of the walls of the hospitals, I didn't know too much about actually until I finished medical school, finished my residency, and they looked at me and they were like, what are we going to do with this guy? We're not going to let him work in our hospital or in our clinics. Maybe we'll let him go out and do home visits, because nobody seems to be doing that. And so really when I finished my training, what I did is I had the good fortune of being able to start doing home visitation for shut-in elders, for seriously disabled, seriously chronically ill, people at the end of life, in many of the high-poverty neighborhoods around Case Western Reserve University, where I had initially joined the faculty. And I learned some things that were, I believe, to be, probably you are thinking, you had to learn this? But after going through school and going through medical school and going through residency, I forgot, or I didn't realize these things. That when you see people in an office or a hospital setting, you're really looking at those individuals through a keyhole, almost a keyhole. Sometimes it's a keyhole into a room lit with a candle in terms of what's going on. Particularly when we talk about people with chronic illness, people that have ongoing conditions that require daily behaviors, modifications of nutrition, management of things like blood glucose levels or their own personal safety, medication management. You really don't know what's going on. And the things I learned when I started making home visits was, that you get a better view of people. You see how they're managing their medicines or not, or failing, struggling, how they're managing their nutrition, how caregivers are functioning. One of the hidden patients in our health system are often family caregivers whose suffering goes unnoticed behind the scenes when they're dealing with people with serious chronic illness. They're often the ones whose health is mental health and physical health is suffering greatly. You get to see them, when you're across from at their table, next to them on their bed. You learn about very practical things. Certainly, when you bring care home, it breaks down access barriers. One of the questions I always had, I went to medical school in Cleveland and public health school in East Baltimore at Hopkins, and one of the questions I'd ask as a student is, how is it that the best healthcare institutions are in the most unhealthy neighborhoods in the country? And you start to realize that the distance between the front door of the clinic and the neighborhood across the street, in some instances, may as well be the Grand Canyon. When we talk about, architectural barriers, for one, this is one of the interesting things. There's a lot of architectural malpractice in this country. We have people, their homes, actually, we call them split-level homes. You walk in the front door, you have two choices, go up or down steps. Well, many humans in the course of their lifespan actually are not able to navigate steps easily because of various neurological, musculoskeletal conditions, cardiovascular conditions. So people become shut in some instances because of that. Other scenarios, there's cultural barriers, economic barriers to care. When you bring care into the home and community, in some cases you can mitigate those barriers. Certainly there's a whole relationship on hazards of institutionalization. Going to the hospital, being institutionalized, is not without risks. There's actually a strong public health and medical literature on the hazards of hospitalization, particularly in the elderly population. We know hospital-acquired infections. We know about delirium, actually one of the most mystifying issues in all of medicine, particularly in elder care, is delirium. People that, when frail elders are hospitalized, be it the change in environment, be it the medications, be it the metabolic consequences of their current condition, they become confused or become overly sleepy, withdrawn. Delirium is associated with higher healthcare costs, it's associated with higher mortality, it's associated with a lot of suffering. We know that when we provide home-based alternatives to care, there's lower incident delirium, lower incident pressure ulcers, other types of common complications of institutional care. In some cases, home care can cost less and is often desired more. And a lot of the consumer research about rehabilitation, end-of-life care, even acute care models, when people can receive care at home in the community, there seems to be a preference. So these are some of the things that I've learned. This is a picture, it doesn't come out well in the light here, but it's a picture of me on a home visit in Shanghai in in the Zabe district with one of the community health physicians, and one of the striking things, you can't tell from the picture, but I'm with the doctor and his patient who is just a month home from having a stroke, where she lost the use of her hand and really was having trouble walking, was more or less shut in because she was in an apartment complex without an elevator, and so it was hard for her to leave. But what's happening is her and her family are reporting that she's doing much better than she had been the month before. And the reason that she's doing better, she's moving her hand better, her mental outlook is better. After a stroke, there tends to be horrible depression because of the loss of function and the frustration and everything. But the room, on the other side of the room, it's filled with potted plants. Plants that had been clipped, potted, pruned, filled. And what had happened was when the doctor made the first home visit, he recognized that she liked plants, and she had a couple plants, and he encouraged her to work with her grandson on potting more plants. It's just something for social activity, to get her mind off her condition, to work with her grandson, but also to manipulate the pruning tools and also the planting as almost like an occupational therapy intervention. And this is just one example, and I can think of many more, where by seeing people in their own environment, by learning about them, that you can make practical changes in the type of care that you might deliver in order to improve care. So these are the things that are exciting about home care. And I think that the exciting thing, when I started doing home care just not that long ago, 2004, 2005, it was really sort of this old-fashioned notion, right? This is like the doc on the horse and buggy, are you gonna do bloodletting and leeches? What's the current relevance? Right, but what's happening, if we look at the mega trends in healthcare, if we look at the things that if you all in your studies, in your research, in your careers identify, the opportunities are endless in terms of figuring out how do we keep people healthy at home. This has to do with the demographic imperative, the chronic illness imperative, the cost of care, and also technology. Technology is changing what we can do at home in really subtle ways, but incredibly meaningful. So for example, when I started doing home visits in 2004, 2005, a couple of the old docs would say, oh, I used to do home visits when I started out, but you'd have to have a flashlight in the morning to map out your visits with the map, and you'd have to know where the pay phones were in order to call back to the hospital to make sure that the nurses at the hospital still had contact with you. And I'm thinking, I never did a home visit without the GPS telling me which way to go, and without having connectivity for my documentation purposes, connectivity at the point of care records. So just mobile and digital technology is greatly changing and enabling what we can do at home. Also, diagnostic technology. So most homes in this country, you can get mobile x-ray. A lot of that comes from technology developed for military in the field. I know many of you at Stevens are veterans. I want to thank you for your service. It's an honor to get to present to you today. But much of that mobile technology has implications for how we can manage healthcare at home. There's point-of-care lab devices. Many of you are probably aware of glucometers, right? The common portable device that people can use to check their blood sugar, that diabetics use to check their blood sugar. Well, the Abbott iStat you can use at the point of care to do about 50 clinically relevant blood tests right at the point of care. We're using this in the home setting more and more. In the future, this will become more relevant. So healthy at home's really part of the future. I'm going to skip a couple of these slides in the interest of time and in your interest. But what I want to point out is that home care is becoming more popular, but we haven't seen anything yet, right? We have the demographics are destiny, right? We can see when we look at the US population that we're going to have over 80 million older adults as you hit stride at the high point of your careers, okay? And many, over 10 million, over the age of 85, okay? And then also, it's not just that we're going to have more older people. The proportion of the population that's older is going to be higher. So if we think about, if you've ever gotten down to Florida and the retirement communities, Boca Raton, Florida, the current demographics of that county, of Boca Raton, Florida, are where the whole demographics of the U.S. are going to be in 2040. So the current age demographics of Palm Beach County, Florida, mirror what the anticipated demographics of the entire United States are in 2040. And then in other places that are older communities, like where I moved from in Cleveland, Ohio, they're going to be even older. Boca Raton, that'll be even older. So demographics are still important. And one other message I think is really important is that this future cohort of older adults, at least the ones that are going to be needing support and help in our lifetime, they are going to have fairly similar burdens of chronic illness and activity limitation and disability as our current cohort. So when we look at whether it's Urban Institute projections, Administration on Aging projections, it's anticipated that we're going to have similar rates. ADL are activities of daily living, limitations in things like ability to dress oneself, difficulty walking, ability to groom oneself, feeding, bathing. These are markers of impairment to the degree. We know that about 20% of adults 65 and older, a little under that, it's really flatline in the trends, have some difficulty with a basic activity of daily living. Really what it means when you have to think about it is when your health condition is so severe that the trivialities of life, the thing that most of us take for granted on a day-to-day basis, are somehow threatened or needing assistance. This has incredible implications for how and where people get health care. The mobility implications really have some implications for healthcare access. And also aging, in addition with activity limitation, goes along with chronic illness. We know that older adults, at least about 90%, these are actually old statistics, the updated statistics, over 90% of adults 65 and older have at least one chronic illness, and then 70% have two or more coexisting chronic conditions. When you combine activity limitations and chronic illness, this is where we see incredibly high cost of care. So for example, for people with any level of chronic condition, maybe they have just diabetes, or they have diabetes and hypertension, they have diabetes and hypertension and arthritis and dementia and depression. These are common scenarios for people in our health system. With more chronic illness and with activity limitation versus no activity limitation, their health costs are more. In the Medicare program, 80% of the cost, and the Medicare program has incredible implications, not just for health care in the U.S., for the entire economy, for our ability to fund virtually everything in our country. The Medicare program has enormous economic implications, enormous social implications. 80% of the spending in that program in a given year is for the 16% of beneficiaries with 5 or more coexisting chronic conditions. So if you're working in the pharma world, if you're working in the disease management world, if you're working in the research world, you may get the impression that we have a diabetes problem, or we have a heart failure problem, or we have a stroke problem, or we have a Parkinson's disease problem. But in terms of the Medicare program, we have a problem on the cost, and I'll tell you from my own experience on the suffering side, for people with multiple coexisting chronic conditions. So people that have diabetes, arthritis, heart failure, depression, dementia, all in the same person. How do we deal with that? How do we help those people? Because that's where the cost and suffering is, not in the people with individual isolated chronic conditions so much in the Medicare program. That's a problem too, don't get me wrong. Rehospitalizations, a big issue in the Medicare program that's become more and more common to discuss, meaning people are hospitalized, they go home, and within a few days, a few weeks, they go back. And it's clear that some of these returns to the hospital are not due to unavoidable consequences of illness. They might be due to, in some instances they're planned. The person has to come back for some type of treatment or therapy, but in many instances it's because things fall through the cracks. They didn't get their medications. They didn't have a caregiver at home to help them with the trivialities of life. They fell. They get another complication. They came in the hospital with heart failure. They come back with a hip fracture. They went in the hospital with pneumonia. They come back with a UTI. This has been identified as an opportunity for performance improvement. One of the things we know is that half of these patients are rehospitalized before they ever, so about 20% of Medicare beneficiaries that are hospitalized are rehospitalized in the next 30 days. Half of those never see a doctor before they're rehospitalized. One of the reasons for this, I would argue, is not just that they didn't know how, that they didn't have an appointment, that the doctor was too busy. A lot of them can't get there. When we're talking about people that have activity limitations and 5 or more coexisting chronic conditions, accessing health care isn't easy. Sending them to the diabetes program on Monday, the heart failure program on Tuesday, the arthritis program on Wednesday, when they live in a split-level home or an apartment that doesn't have an elevator, there's not transport, maybe they need a caregiver to leave the home because of cognitive impairment, other social issues, have to bring an oxygen tank, a wheelchair. this is a problem. This is a problem. So there's all sorts of current types of home care, and I don't want you to get caught up in it, because I think that your opportunity and the areas that you can make an impact as you learn more about healthcare and about economics and about technology is not so much in the way we deliver care now, but how do we break the current reality? How do we change? How do we get out of the current paradigms, the current payment models? It's boring, right? It's yesterday's news, sort of beaten paths are for beaten men type of stuff. How do we change? How do we change the paradigm? But most of my work for our organization is in what we call a home health agency. We have visiting nurses. They provide intermittent home visitation. We're paid in 60-day lumps, 60-day episodes by Medicare. Physicians need to certify that they're quote-unquote homebound, so that patients really have difficulty leaving the home, and that they have a need for nurses or therapists in the home. In this Medicare model, actually, it's under a lot of threat. There's about 12,000 Medicare certified home care agencies across the country. We're one of the biggest ones with Visiting Nurse Association. We're seeing payment cuts, potential implementation of co-payments, a lot of program integrity measures, because one of the problems with home care is that it's out of sight, out of mind, and it's been an area where there's been, unfortunately, a lot of cases of fraud and abuse. Maybe technology can somehow solve some of these fraud and abuse questions and make sure that when people bill for something that's done in the home, that it was actually done, that the people actually did it, that the caregivers actually showed up and did what they were supposed to do. A lot of issues here. A lot of problems with that Medicare home health model. Other types of care at home is more what we call custodial care. Okay, and this gets blown off, right? It's not even health care. We don't even talk about it in medical school. This is homemaker stuff, right? Help with bathing and grooming. You don't even barely need a license to do this stuff. It turns out, though, if you don't have this stuff met, like if your activities of daily living aren't met, if you don't have a way to bathe, groom, feed, dress, move, maybe some companionship, tender loving care, human touch, interaction, you have nothing. There is no health. The best pharmacotherapeutics, the best disease management plans, the best advice, all of those things are almost useless if your basic needs aren't met. And one type of home care is custodial home care. And with an aging population, high burden of chronic illness, high burden of cognitive impairment and dementia, we're going to have big custodial care problems in our country. We send people through the front door to come and help at home attendants, homemakers, home aides. It's actually in many cases, in many parts of the country, it's a poverty job. Basically, people are barely able, it's a very low wage job, not great training in many instances, not great benefits. It's also a big challenge. How do we raise the bar? How do we do better? Some of it, there's a big black market, if you will, under the table market of caregiving, in that families and people hire people sort of out of pocket, outside of the tax system. Maybe they get a better deal in those instances. Maybe sometimes they get taken advantage of. Big area. How do we change this? Because technology, I would think, both the combination of new ways of organizing and delivering care with new technology should be able to change this. How do we help people socialize at home using remote-to-home video concepts where they can have socialization opportunities with family members and have activities and have opportunities for recreation? How do we make sure that the med management happens, that it's not always has to come through the front door, that some ways it can come through the mobile device, that in some ways it can come through some other type of sensor? Do we always have, just because somebody's cognitively impaired, does that mean that we have to have a personal attendant in their home 24/7? Is there any way that we can monitor that environment for their safety and well-being so that there can be periods of time when they don't need that human resource for their own autonomy, for the cost, what have you? Big opportunities. Hospice care at home, it's often overlooked. Many people think of hospice as a place. The vast majority of hospice care, would be an end-of-life care model, is in the home setting in the United States. Most hospice patients are taken care of in the home setting. More and more people late in life are electing for hospice care at the end. It's a great model for helping people stay home at the end of life. For certain frail elders, particularly people with multiple chronic conditions, activity limitations, in some instances hospice care and palliative comfort-oriented care is actually life-prolonging. We've seen in the medical literature because of the focus on the holistic aspects of care, nutrition, personal care support, support of the caregivers, comfort. We actually see in some subpopulations life lengthening through these types of models of care where there's often medical futility. So hospice at home. And then there's these new models of care. There's a concept called the medical home that's, if you know about it, it's sort of the new approach to primary care. It's the general internal medicine or general pediatric or family doctor's practice of the future. And they're going to be, it basically involves better information technology, better tracking of certain metrics in their population, better care coordination. Because one of the problems we have in our, we have no care coordination. Lots of articles about this now. It's really basically what happens to people between billable events in this country is a big black hole. We don't really coordinate this. Some people are better able to navigate. When you're the family caregiver, that sandwich generation, and mom or dad have the 5 coexisting chronic conditions and 3 activity limitations, and you've got other concerns. Care coordination is a really big issue. So how do we bring home that medical home model? Make sure it's not just an innovation in the primary care practice, but that extends to the people who are hiding in the shadows, the ones that are costing the most and suffering the most. It'd be really a shame if we really did a great job innovating care for the people that weren't costing the most or weren't suffering the most because they were the ones that showed up in the office. That would be a mistake. We want to go where the money is. That's sort of the Sutton's law of healthcare, right? The 19th century bank robber that said that the reason that he robs banks was because that's where the money is. It may not be in the waiting room of the medical practice where the money and the suffering is. It's the people that aren't there. And why aren't they there? There are a lot of questions to be asked. But home care is going to change. There are going to be big opportunities to be a vendor, if you will, to manage care organizations, to new accountable care organizations in a variety of different ways. There's going to need home visitation. As these organizations' payment models change, they're going to need people to do risk assessment. They're going to need people to do quality assessment because all these payment models are going to be based on risk assessment and ultimate cost of that population and quality outcomes. And home visitation may provide ways to help better navigate the management of certain hard-to-reach folks. Medical house calls, more physician-based home care, hospital at home. One of my colleagues at Hopkins, Bruce Leff, has for 2 decades in the US, and European models are even more well studied, has delivered a model of acute care, hospital substitution in the home setting. The frail elders in the emergency room, meeting hospitalization criteria for an exacerbation of heart failure, pneumonia, chronic obstructive pulmonary disease. They fit the bill for they need to be hospitalized. In 99.99% of hospitals in the United States, the next thing that the emergency room physician does, it says admit to the hospital. In the hospital at home model, the next thing they do is they say go home. And what they do is they triage the patient's home with home visitation, telemonitoring, home infusion services, more intensive than usual home nursing and aid services. Interestingly, they're basically taking the lower end, the lower acuity end of the acute care spectrum, right? So they're looking at, is there marginal hospital care? Are there people that, at the low acuity end of people that currently meet criteria for being in the hospital? Can we provide a substitutive model at home, where they're less likely to incur the hazards of hospitalization, where their convalescence may be shortened, where their costs may be lower, and where their outcome in terms of their experience may be better. A lot of different studies on the hospital at home model look very promising. And then new palliative and advanced illness cares. I'm going to talk a minute about technology and then I'm going to be done because I know we got a short block here and I saw what it looks like out here on your campus. I know the last thing you want to be is here. I mean, this is just a beautiful place. You've got the Manhattan skyline, the flowers are out, there's wine and cheese in the lobby. I'm actually questioning all your judgment for coming to hear me speak. But technology, and again, not technology just for technology's sake, probably not technology in and of itself. If we're talking about this sick, chronically ill population, but technology is a part of new models of care, new models of organizing care, new models of financing care, new models of delivering care. Technology offers so many opportunities to help more people stay healthy at home, to lower these costs, and at the same time as lower costs, reduce suffering. Because one of the ironies, one of the paradox, if you will, of that high-cost group of patients is that they're suffering immensely. They're suffering, their care is fragmented, the healthcare system takes on these monolithic qualities in many instances, and their outcomes are often poor. So big upside, big value creation opportunities. We look at the value creation in this population are enormous. Remote monitoring. Daily monitoring of physiologic concepts, weights, blood pressures, oximetry, glucose, other lab parameters, may have a role. Blood pressure, heart rate. We're seeing some anecdotal success. I'd say the evidence is mixed on where and how this works. Device monitoring is an interesting concept. Monitoring of implantable cardiac devices, in particular, monitoring of potentially even orthopedic implants, knee implants, other types of implants, in terms of helping aid and inform recovery and in the process. Monitoring is interesting. I think that we're also going to see a lot of value created out of just virtual encounters. Basically, how do we bring clinicians into the home, into the community through mobile devices, through smartphones, if you will, the virtual visit. M-Health applications, self-management. What does that ATM for the caregiver look like? Why is it that when my aunt is at home in hospice and is, really has her pain pump in her home, really in her last couple weeks, wanting to be home, wanting to be comfortable, this pain pump is going off and beeping, okay, and the light's flashing, and me and my cousins are sitting there trying to figure out how to stop this pump from beeping. Why is it beeping? Is it not working? She's getting anxious. Maybe she's not getting her medicine. We're worried we're going to have to take her out of the home. It's not working. Why is it that I have to call through some sort of like Soviet phone tree in order to get somebody to help? They have to page somebody. They have to page somebody to call me back. And then when the person calls me back, and I tell them that the pump is beeping, they have no idea what the make and model of the pump is. They're not sure if it's the, this. Why isn't that all available on platforms for self-service in some instances for empowered patients? For at least that the clinician that would be helping me would be able to look at a diagram or a map of this or a manual in order to help walk through, and she can say, it's, in this particular model, you have to touch this pump to reset or whatever, and so finally she talked me through it after she called back after talking to her manager to confirm what the pump was, and only because I was a physician and I was in charge of the hospice program was she willing to do it over the phone, and otherwise on a Friday night she would have had to make a visit. The waste there, taking this value, this highly trained nurse who's covering for 400 dying patients at home on a Friday night while we're all out, having it all, we're with our families and comfortable. She's got all these patients to take care of. She's got to get in a car, 59 cents a mile of gas, whatever it is for insurance, drive and be tended away to do something that I probably could have done on my own if I could have just pressed a button and somebody would have said, pump is beeping, do this, that, and the other thing before calling. Why can't we do this? I can book a plane reservation before I leave this room, but I can't get this pump to stop beeping. The pump is like 1980 technology. Mobile diagnostics, I mentioned that, a role. Information system interfaces and integration. Big upside opportunities, big improvement opportunities. How do we get better information at the point of care? Diagnostics, ultrasound, these are things. When I started medical school not that long ago in 1997, this device here, this ultrasound, was something the size of a dishwasher, and now it's something you can fit in a pocket. When and how we need this in the home and community setting, I think that's a question. I see more opportunity in many instances for the care coordination opportunities, for the care management, the virtual care opportunities. So that's the Abbott iStat. So technology inside models is going to fill the white space in between our visits, in between our encounters. In some cases, I believe in home care in particular, technology isn't going to diminish humanism. It's going to elevate humanism and compassion. We're very high and mighty, right? We bring a nurse or somebody into the home 3 times a week for 45 minutes. But many of these patients and families have 168-hour-a-week problems. How do we fill that white space? How do we improve their connectivity in between? Improve their experience, reduce costs, and then in some cases, there are marginal visits. There are times when encounters aren't needed in the home. When we have 70 million baby boomers to tend with in their 80s, we're really going to have to figure this out. We're not going to have somebody we can send everywhere. So, I'm going to skip that. I think that my organization, Visiting Nurse Association Health Group, it was actually started by a woman, Geraldine Thompson, in 1912, who was a lifelong friend of Franklin Roosevelt's and also a lifelong friend of Eleanor Roosevelt's, President Roosevelt's wife. And one of the famous quotes from Eleanor Roosevelt is that the future belongs to those who believe in the beauty of their dreams. And the neat thing about that, and I have a picture of our founding person, Geraldine Thompson, with Eleanor Roosevelt in that saying in my office, because I think it's amazing that they really believed that they could really change care for the communities that they lived in. They made a huge difference, and now have their legacy as a 100-year-old organization serving the people. But my last boss at Cleveland Clinic, Toby Cosgrove, said that the future belongs to those that seize the opportunities created by innovation. And I think that both sayings ring true, and I think that there's a huge opportunity to elevate compassion, to increase value, to help more people stay healthy at home by thoughtful innovation in home and community-based care. And I hope some of you will consider this as something that you look into as parts of your career. And that's all I wanted to share with you. Thank you for having me and for letting me spend some time with you. If we have time for questions, I'd be happy to try and address them.
Thank you, Dr. Landers, for a most inspiring talk. We now want to have roughly 10 minutes for Q&A. If you need to leave for class, it's probably a good opportunity to head out through the left-hand exit over here. All questions are welcome, and please share your questions. Go ahead.
You mentioned that studies need to be done to look at quality outcomes. A little surprised that there haven't been any comparative studies to look at outcomes, economic, political, quality of life. The comparative obviously would be whatever the alternative. Assisted living.
So there's a pretty deep literature on home-based models of care. So but whether or not the model that has been tested is the way that we've implemented and translated, there are some questions there. So I think if we look at hospital at home, if we look at home-based primary medical care in the Veterans Affairs system, if we look at home-based rehabilitation after arthroplasty, after knee replacement surgery, if we look at home infusion services for patients requiring long-term parenteral antibiotics as an alternative to office-based infusion, alternative to facility-based infusion services, there's a pretty rich literature on home-based models of care. Absolutely. I think that on the question is, I would say that there's more concern as to whether or not our current models are actually the current actual implementation models, the way that we're actually delivering home care in the private sector, so to speak, outside of the research environment, whether or not we're making the impact that we've seen in many of the studies. I'd say that probably we're not in most instances, because we've not really taken that evidence to heart. We've more sort of followed where's the golden goose in the the Medicare program or the Medicaid program, rather than where's the evidence point us.
So have you seen other cases in other countries that have different healthcare systems that have more government involvement in the healthcare, where these types of practices are more advanced?
When I am certainly no expert in comparative health systems and even comparative home care. And what I can tell you is that when I do look at the literature in home-based care, it seems like there's a predominance of models described in Australia, in the Netherlands, in Israel, that seem to be more thoughtful approaches to care at home. There may be other examples. I'd love to personally learn more. I just haven't, it's not been an area that, there's probably a lot that we could learn in the US as well. I did some work on the technology side. I think there's some interesting developments on the sort of that social model, that safety and activity of daily living support model going on in Europe. I was working on a startup with a group out of Ireland that had some interesting models when I was at Cleveland Clinic. I don't know if it was just happenstance that we were working together, or if they actually were their leading edge in that regard. I just don't know.
Regarding your 9th slide on percentage of Medicare expenditures, it says that if you have 3 chronic conditions, you take up 10% of all expenditures. But if you have 4, you have 9%. So if by chance, and if I have another chronic condition, I will pay less versus having 3.
I think that it may not. You know, exactly why that's the case, I don't know. It seems like in most studies that's one cut of 1 year of Medicare data. I think we're looking at, that comes from the Partnership for Solutions data, and it's one cut of 1 year of Medicare data. When we look at health plan data, when we look at year-on-year Medicare data, when we look at Medicaid data, it's pretty clear that increasing chronic illness burden trends with increasing healthcare costs. But in one cut of the data, there may be some nuances there that for some reason or another, there may be an error in the way that we cut that pie chart, and I'll double check. But you know, in general, I think in multiple populations, in multiple data sets, it's been shown the more coexisting chronic conditions that people have, in general, that relates to healthcare costs pretty tightly.
I think it's, a lot of that could be the coding system. I mean, there's a lot of confusion.
Oh, yeah, this is,
Comorbidities, diabetes, and cardiovascular associated with condition to a lot of symptoms.
well, I think that you could make that case, sure. What is what is the etiology? You know, you could sort of look at it from that perspective. Although I can tell you, in working with thousands of frail elders in the Medicare population, generally speaking, we are looking at a population of people that do have truly distinct aging, multiple age related conditions. Some of them are linked to one another through some type of sequential pathophysiological mechanism, but in many instances they're not. There are many natural consequences of aging that in combination with some other pathological processes manifest as disease, and we're talking about people that have diabetes and Parkinson's disease and depression and an osteoporosis. By and large, I think that there is some of that coding. And there is some element of utilization, right? So the more people use healthcare, the more codes they collect. And then the more codes they collect, then the more they cost. And there are imperfections in the assessment, right? So it's no doubt. I think that overall, the cost data align well with the conceptual model here. So, but the nuances certainly are to be noted. Absolutely.
So, like you were saying, the most costs are with the most chronic conditions, 5 or more. How is the VNA attacking that group? Because that requires more and more advanced technology, and that's difficult to do at home.
Yeah. So, interestingly, that's an interesting question. I would actually argue that in many instances, it's not necessarily advanced technology, it's the application of fairly simple technology that's going to make the biggest differences. So, for example, making sure, when I say simple technology, I believe information exchange, moving data between data sets, visualizing data in clinical information systems. This, in my view, shouldn't be advanced. In healthcare, we call it advanced technology, but it's not advanced technology. This is pretty basic stuff. We could look at patient information. If we had the information. So at the point of care, our clinicians have a point of care information system for our own clinical information systems based on a Samsung Galaxy Tab that allows them to have windows to the extent that information can be interfaced and be brought in from other providers. They're able to visualize that as part of their care. And one of the big opportunities for care improvement in these people with multiple chronic conditions is not any wild technology. It's actually in reconciliation, deduplication, making sure that things don't get overlooked, making sure that dangerous things don't happen. Because if you get the best diabetes care for just diabetes, and you get the best arthritis care for arthritis, and you get the best heart failure care for heart failure, when you merge all those together, you get pretty crappy care because there's many drug-drug interactions, there's drug-disease interactions, there are things that are impractical. So a lot of what needs to be is care coordination, it's individualization, and then also a couple of the big issues, reasons people are incurring costs, unaddressed basics of life. custodial care. And our nurses spend a lot of time, how do we make sure there's an okay caregiving plan? And people not every, oh, that's nice, but that's really not the issue. No, it really is the issue in many instances. I had a 92-year-old patient hospitalized 6 times in 4 months for abdominal pain and vomiting, okay? Goes in the hospital, gets endoscopy, gets blood work, gets surgical consultation. They come and they press on her belly and check her out. Multiple lab work, enzyme studies, gets, various types of pharmacology, okay? And after a day or two, she was fine. And, she said, yeah, I feel fine, doc. Send me home. They don't really find anything. CAT scans, cholangiography. I mean, anything you can think of, okay? Comes back a couple weeks later. Same thing, abdominal pain, vomit. Everything's okay again. Gets the $1 million work, goes home. Finally, after her last hospitalization, the doc at the hospital said, Steve, will you go and see this patient? I don't know why she keeps coming back, but she never goes to a regular doctor in between our visits. Maybe there's something going on. Will you go see her? I go and see her. She has no idea who I am, even though we called to set it up, but she's happy to let me in. And when I come in her house and sit down to talk to her in her kitchen, her whole, first of all, she's incredulous that she'd been in the hospital at all. She had no recollection of being in the hospital. And her kitchen is filled with spoiled and burnt food, okay? And one thing about Alzheimer's disease to recognize is that early in the disease, people's social graces are quite well preserved. So the, yes, doctor, thank you, doctor, my daughter will be here to pick me up at 2. And you ask them who's president, and they'll say Jimmy Carter, okay? Or they won't, or you ask them, who you are, where you are, they won't know. But the social graces, so this is an example of a person who's having abdominal pain and vomiting because she was eating spoiled and burnt food. The reason she was eating spoiled and burnt food because she was unable to continue to manage her activity of daily living because of early dementia, okay? And these are the scenarios where the visiting nurses can make a big impact. So this is a person that she actually had low vision, she had arthritis, and she had dementia. The combination made it very difficult for her to deal with the basics of life, like meal prep in a safe way. Those are places we can help make a difference. When we can coordinate the information that we're getting in the home with other providers in other settings, communicate better. Maybe if somebody had done a home assessment earlier, she went to the hospital once, people would have put the dots together. So this isn't, we're not, going to be x-raying people through their windows at the VNA as a model of success. But this is where we can drive some value, reduce costs, improve suffering, and there are a lot of applications for technology as well. But that's a long answer. You know not to ask me a question now.
Time for one last question. Anybody? Please.
Kind of going off how you were talking about technology and innovation for healthcare, I think you made it very clear that stuff like remote modeling and virtual visits would help the patient, but you also mentioned Medicare, and with the financial status of the world and our country right now, how do you think you'd try to convince people that that would be worth spending money on?
Yeah, so I think
Just
there's 2 models that are emerging, okay? So what the answer is not going to be is another, I sure hope it's not going to be, another toll booth, okay, another per-click type of thing, okay? Because what happens is when we come up with a new healthcare technology and our financing model is per click, we get more clicks, okay? We get, the payer opens up a crack and we drive a train through it. And the marginal utilization is so much that the value creation is diminished. We're going to see a consumer model for certain things. And then on the healthcare side, by and large, we're looking at cost avoidance models. So to what extent can this use of technology participate in reducing costs? In either reducing the unit costs, so like for me, my home health agency, I get paid $2,500 to provide 60 days worth of home care to Mrs. A. We go out 3 days a week with a nurse. It costs my organization XYZ in order to do this. We hope that it costs us, $2,499 because they paid us $2,500 to manage it. Maybe there's a technology solution that's going to help me deliver a better outcome for $1,500, okay? And that's going to allow the continued price pressure to move forward. Maybe you can help, there's cost avoidance models. Maybe on the insurance side, on the payer side, or in these integrated models where the payer and provider are combining, the accountable care organization, the provider that's put at risk in capitated models. In these scenarios, it's no longer, well, why don't they pay me for this? It's, here's your payment. You figure out how to deal with it. We're seeing many more of these bundled payment, episode-based payment. These are all areas where providers are being put at risk for populations or for longer lengths of care around a scenario. Once the payment shifts to those scenarios, the question about the technology is, can you save money? And in that extent, it's going to be more of a B2B type of model, where the large provider organizations have technology vendors that support their value creation. That's the way I see it.